This is out of your Lewis text, Chapter 40, Nursing Management of the Patient with Nutritional Problems. So, nutrition is essential for our body, for energy, for growth, for maintenance and repair of body tissue. The daily caloric requirements for a person is 20 to 35 calories per kilogram of body weight. And it's really critical that, if the patient is, an athlete, or they, or pregnant, that those calories are adjusted for their energy expenditure. So my pyramid, our government has set up a food pyramid by the U.S. Department of Agriculture with recommendations of servings of different foods that we need per day. Really, the oils and the fats should be minimal in our daily diet, and we want to get more of the grains, the fruits, and the veggies. We need some dairy, and we need some meat and beans for that protein. This table just shows the some good sources of proteins, complete and incomplete, our major minerals. So vegetarian diet. This is vegetarian is becoming pretty common. They can be vegetarian where they only exclude red meat from their diet, or they can be vegans. And a vegan is somebody who doesn't eat any animal byproducts. So oftentimes they won't eat dairy products, or they won't eat any eggs. But whether they be vegetarian or vegan, it's really important that you do a thorough diet assessment, because they can have a protein deficiency and a vitamin deficiency. And so oftentimes they'll need to use supplements like vitamin B supplements and protein supplements to get all their essential elements in. It's important to be culturally competent with nutrition. We know that each culture is different. They eat different foods. They have their own religious beliefs or cultural beliefs that affect our diet and how we eat. I think of like the Jewish patient and making sure that foods are kosher. And when they're in the hospital, it is our job to make sure that we're catering to that cultural and ethnic background. And so make sure that you do a thorough diet assessment upon admission. Like religiously, I also think of, like during Lent, Catholics can't eat red meat on Fridays. Malnutrition. This is a deficit or excess or imbalance in the essential components of a balanced diet. It can be an alteration of any type of nutrient. There is undernutrition, where they don't take enough in, or overnutrition. That's where they take too much in. So this would be like the obese patient. Undernutrition actually is not only a problem in underdeveloped countries, but even in the U.S., we have people of low socioeconomic status that can't afford to even eat, or maybe they're obese because they can only afford to buy the 38-cent box of macaroni and cheese at the store. So protein calorie malnutrition. This is the most common form of undernutrition, and It can be from a primary or secondary factor. A primary is when nutritional needs are not met, and secondary is because of a deficit in like the digestion or absorption. So this would be like a GI disease that would impact the absorption of the nutrients. Meramis, this is one of the most severe forms of protein-calorie malnutrition. This is when there is loss of body fat and muscle. Kwashiorkor is when there's a deficiency of protein intake, and this patient will have edema and really low protein levels. Oftentimes, the marasmic and kwashiorkor is combined together, and the patient will have a lot of tissue wasting. They'll just be really dehydrated, very thin. So the etiology, there's many factors. We talked about socioeconomic factors. There again, obesity and undernutrition can be both caused by, a lack of financial resources. Physical illness, again, that could be anything from hospitalization to surgery to illness. Incomplete diets, this is like vitamin deficiencies. And there again, vitamin deficiencies can be caused from low socioeconomic factors. I think back, I took a missions trip this past spring, and you just wouldn't believe the amount of people who are lacking vitamins, and just to be able to bring in, a 30-day supply for each patient of vitamins. I mean, they just were so thankful for it. But you could just see the malnutrition and, with undernutrition and the lack of fat they had, and, some of the defects from vitamin deficiencies. Food and drug interactions. This is caused, it could be from, I think of warfarin and vitamin K interaction. We know that foods high in vitamin K, like the green leafy vegetables, some dairy products and some meat products are high in vitamin K, and it alters coumadin because the coumadin is trying to thin the blood, and vitamin K will cause the blood to become thicker. So starvation. So initially, when we don't eat, our body uses up all of our carbohydrates rather than fat and proteins to meet metabolic needs. We have carbohydrate stores that are in the liver and in the muscles, but these can be totally depleted within 18 hours of not eating. Eventually, when starvation is prolonged, like 5 to 9 days, the body starts using our fat to supply our energy needs. Fat stores can be used up in little as to 4 weeks. So the clinical manifestations. So malnutrition, the most obvious signs are going to be physical examination. They're going to have dry, scaly skin. They'll have like some hair loss and brittle nails. They can have some ulceration in their mouth, decreased muscle mass, weakness. They can have some confusion. Really, it's going to depend on how malnourished the patient is as to how severe the changes are. Malnourished individuals a lot of times are anemic because they don't have enough iron and folic acid. So diagnostic studies, it's important to do a history and physical. You're going to get a diet history of what they've eaten over the past week, because that will give you an idea of what types of foods the patient eats, what their dietary habits are. You're going to want to get a height, weight, vital signs. So lab studies will need a albumin level. A lot of times patients that are malnourished will have low albumin levels. They can get a C-reactive protein, which measures inflammation. And this will help determine to what extent of low protein they have. You'll need to get an electrolyte level. Oftentimes they'll have an elevated potassium. Get a hemoglobin hematocrit. That'll indicate anemia. The lymphocyte count will decrease in a malnourished state. They may have elevated liver enzymes. Anthropometric measurements. This measures fat and muscle. They'll measure skin fold thickness. That might help give them an idea of hydration status as well. So nursing assessment. We're responsible for nutritional screening. This is done on admission. Find out any history of weight loss or weight gain in the last month. Do they have any chewing or swallowing issues? Is there skin breakdown? In home care, we have a diet section on in a form called the Oasis, and that's an assessment for home care. So you'll find out their oral intake, their dental hygiene, again, swallowing difficulties, and if they need meal assistance. There's just a picture of malnutrition, undernutrition. There is a Homley formula that shows the desirable body weight formula. So for women, 100 pounds for the first 5 feet plus 5 pounds for every inch thereafter. So if a woman is 5 feet 5 inches, their ideal weight should be 125 pounds. Men have is 106 pounds for the first 5 feet and 6 pounds for every inch thereafter. For a small frame, you subtract 10%, and for a large frame, you add 10%. So nursing diagnoses that you might see: imbalanced nutrition. This can be less or more than body requirements. Self-care deficit, deficit fluid volume, risk for impaired skin integrity, because if they don't have that protein, they're not going to heal. Activity intolerance, they don't have that energy. So you want your overall goals for this patient. If they are undernourished, you want them to gain weight. If they're obese, you want them to lose some weight. You want them to stick to their diet plan and have no adverse consequences. You just want to teach good nutritional habits, identify nutritional risk factors. We know that when a fever is present, the metabolic rate will increase. So oftentimes this patient will need more calories. You can use, for the patient who's not taken enough in, you can use protein shakes or meal supplements like Boost or Ensure. When considering the elderly, they're really vulnerable to malnutrition. And again, the elderly are at risk for skin breakdown, so they're more likely to have poor wound healing, pressure ulcers, infections, decreased muscle strength. This population, they have changes with their taste buds, so they don't want to eat. Nothing tastes good to them. They have problems with swallowing. Or, maybe they're alone and they don't want to cook for themselves. So they just don't eat. Or maybe they don't have the ability to go to the grocery store and don't have anybody to go for them. Chronic illnesses can cause problems. Depression, some medications can decrease appetite. So there again, it's really, really important with the elderly to ask them, tell me what foods you've eaten in the last couple of days. This is going to give you an idea of what their diet is, what they have access to. You can make referrals to community meal program. Most communities have like a meal site where they can go for lunch. It's usually Monday through Friday. They have Meals on Wheels that will deliver lunch Monday through Friday. Some places will do like frozen meals. Like a lot of nursing homes will cook up meals and you can order them. They'll freeze them and then they'll deliver so many meals to their home. If they don't have the income, we'll refer them to like a food shelf. So types of nutritional support: oral feeding. There again, for the patient who has a deficit in nutritional intake, the high calorie supplements like Boost, Ensure, instant carnation breakfast provide a good source of protein, but it's really important that the patient knows not to use them as meal substitutes. They are meal supplements, so they could be drank with their meals, or you can use them as snacks in between meals. You'll see them a lot in the nursing homes. We'll give them with medications. Enteral nutrition. This is tube feeding. This is feeding via a tube through the GI tract. This can be for anybody who's like anorexic or has like a facial fracture and they can't eat, or cancer or psychiatric condition. They can give it by pump or by gravity or bolus through syringe. NG tube is the most common, used for short-term feeding problems. They can use a gastrostomy tube or a jejunostomy tube, and that will put the nutrients right in the jejunum. There's just a picture of the tube placements. So there again, the nasogastric tubes. So when they insert them, position will be confirmed by X-ray. When placement is put into the small intestine, it decreases the likelihood of aspiration. The smaller tubes they clog easier, and it's harder to check for residuum. So make sure that, I talked about checking residual, make sure that you're checking residual before you're giving feedings to make sure that gastric emptying is occurring. And then make sure that after you're giving medication, you're flushing the tube. A gastrostomy tube or a jejunostomy tube is when a patient needs enteral nutrition over an extended period of time. And this is used because it reduces the risk of aspiration. They're placed surgically. So the procedures for tube feeding, make sure that the patient is at least a 30-degree angle, but preferably a 45-degree angle, because you're going to want to prevent aspiration. There again, make sure the tube is patent, like flush every 4 hours during continuous feeding, or before and after each feeding. That's also with medications. You're going to flush with sterile water. If you use like a kangaroo pump, you can automatically program the pump to flush the water before the feedings, and you can program it to pump or to flush every 4 hours. You need to make sure that there is an X-ray confirmation, or if you feel like the tube is not in the right place, then get an order for an X-ray. You're going to want to make sure that you're checking residuals every 4 hours. If you have more than 400 mLs of volume, the patient is at increased risk for aspiration. You're going to want to make sure that you're listening to their lung sounds. When you're giving medication, you have to flush with at least 15 mLs of water. Don't put the medications into the formula. This patient will need to have daily weights. Watch their skin for any irritations if they have like a gastrostomy tube or a jejunostomy tube. You're going to teach how to care for the feeding tube. Parental nutrition. This is where administration of nutrients by a different route other than the GI tract. Oftentimes it'll be through like a PICC line. They'll do it via IV. This is often for patients who've had like an injury, surgery, burns. So pharmacy will make up that bag. You'll hear it called like TPN or PPN. It's made out of calories, proteins, electrolytes. There will be trace elements, vitamins. So methods of administration. Enteral. PN is when long-term support is necessary. So this will be through a central line. There again, I talked about it going through the PICC. The peripheral is through, it's used for nutritional support for a short period of time. Usually the protein and calorie requirements are not too high. There again, it's made by pharmacy. Make sure that you're using clean technique when hooking them up. So, home nutritional support. So the patient who goes home on TPN, make sure that you're educating the patient on proper catheter care, proper tube care, the side effects, complications. Eating disorders. Anorexia nervosa is where there is a self-imposed weight loss. It is a mental illness. It affects more women than men, oftentimes younger women. The patient may fear gaining weight, so they just won't eat. So some of the symptoms you'll see is they'll have some hair loss. They might not have their menstrual cycles, or it'll be irregular. They'll have dry skin, constipation. You might notice that they'll exercise a ton. So diagnostics, the patient will have anemia, an elevated BUN. They'll have a potassium deficiency, which can cause cardiac dysrhythmias and renal failure. So care for this patient, they may need to be hospitalized. They'll need to go through an intensive counseling program. Bulimia nervosa is where the patient will binge eat and then induce vomiting. They might use a ton of laxatives or diuretics. And then you might see them exercising a lot. I actually had a friend who was bulimic, and she started losing her hair. Her hair was very thin. They'll have problems with their teeth. They'll have dental problems. There again, hair loss. They may have broken blood vessels in their eye from vomiting. Oftentimes, again, it's the female population. And then they need to be treated with counseling, medications.